Hello everyone, my name is Lorna Breckle. I'm the Family and Volunteer Support Manager based here at Rampton Hospital. I would like to welcome you today to our very first virtual Social Visitors Event Day. We have a variety of hospital managers giving updates today about various topics, so please enjoy. Thank you.
Okay, so we've made some changes to shopping. So whilst COVID has been affecting the hospital, we had to stop the patients visiting the shop. That was from the end of March. When they were not able to visit the shop, they were submitting shopping sheets, and on the shopping sheets it limited the amount of goods that they could purchase. So we've been working as to how we can reintroduce shopping for patients. Those of you who attend carers events will know we've been working on this for a while. So from the 1st of June, we've reintroduced shopping to the hospital shop, but half the ward will go at a time. So patients will go to Zest once every 2 weeks. The shop's been organised with social distancing in mind, so that there's a maximum of 3 patients that would shop at any one time. But we've taken this opportunity to remove the chocolate, crisps and fizzy drinks from Zest. So those red items, or the chocolate, crisps and pop, will be available via the shopping sheet. So this is something that's been seen as an opportunity to limit some of the excess purchasing by patients. Actually, you know, they can still buy a significant amount, which I'll come on to in a minute, and it is what they're used to doing on their shopping sheets. So if we look at what they can buy with this, so there's limits around crisps, 10 packets, chocolates, 10 bars of chocolates, 4 packets of biscuits. There's drinks there outlined, and they can buy some other items. You will note that there's no limit on the amount of fruit that they can buy, and they can still buy fruit and the grocery items when they go shopping once a fortnight. So at Zest, we're looking to increase lines on toiletries, the children green items, activities and gifts, and we're consulting with patients about what additional items they want to buy. So at the same time, we've got an online shopping pilot going on, and this is commenced also on the 1st of June, and that's in Women's Services on Ruby Ward. We're using Asda George for that online shopping, and it's going reasonably well. The reason we chose Asda George is because they've got a 100-day returns policy, so it gives us plenty of time to get the deliveries in, to see if it's right for the patients, and then to return it if it's not. So we'll be reviewing that after 3 months with a view to rolling that out in Women's Service, and then after that, a further review, it'll be rolled out to male services. Okay, so that's where we're up to with shopping. Late yesterday afternoon, we finally got a plan for how we can introduce a combination of limited on-site visiting and virtual visiting. That will become available from the 22nd of June. It will be in conjunction with clinical teams who will decide what is the appropriate type of visiting. So not everyone has technology, not everyone visits regularly. There are some patients that are more adversely affected by the reduction in off-site visiting. And clearly we're working with government guidelines around safe visiting. So the NHS guidance brought out on the 5th of June around hospital visiting gives us some guidance. So that's 1 visitor at a time. We would be using the off-ward areas, so the daycare areas, and it would be limited to 1 visit per service at a time. So we're also looking at introducing virtual visiting. We've said from the 22nd, so we can get a booking a system in place. The booking will come through social care, so that you would ring social care, and we will then liaise with the wards about what is available. The sessions will be a range of sessions across the day and evening, and we need to sort of firm up with wards about what will be available. Lee, do you want to sort of carry on from that good news?
Okay, I think you've captured most of what we needed to convey. It is a development in line with the government instructions relating to visits into healthcare establishments. The reason why it's one visit at a time really is about making sure that it's safe, safe for patients, safe for yourselves as visitors. And it means that we can wipe down and clean the visit areas between visits as well. But as Lynn alluded to, rather than just stick with the historical morning and afternoon session, we're going to see whether or not we can facilitate evening sessions as well, because we know that the demand might well outstrip the supply, particularly early on. In line with that, what else is happening relating to virtual visits? First and foremost, I have an apology. As an organisation, we've been trying to get virtual visits using Skype for Business running for about 6 to 7 weeks now, and we've only just managed to get it working. The background to that is that our health informatics service, when we first contacted them, they couldn't run it over our network because of the demand, and so they wanted it to go on what's called a virtual private network, which then we needed to liaise with an external provider. That took time. The initial testing of the services, it didn't work, and we've only just managed to get into a position where it's been handed over to me and my team so we can do testing, and we'll be doing that testing this week. Essentially, what a virtual visit will comprise of is it will be a three device visit. There'll be, the patient will have a tablet. You will obviously have your laptop or your tablet at home, but the member of staff who is supervising the virtual visit will also have the Skype on their laptop, and what they'll be doing is that they'll be controlling that virtual visit. So again, what we're trying to hopefully do is do all the testing this week, roll it out, and then start taking bookings through social care and being able to take this forward from, I think it's the 22nd. What also we'll want to do is try and give every single carer, every single patient who wants to make use of this opportunity. So therefore, I think we're going to be looking at limiting initially the virtual visits to about a 20-minute session period, which enables us to get more of them done. There are some concerns that we have to take account of relating to risk, and so there will need to be a risk assessment which is endorsed by the wider multidisciplinary team relating to the use of video visits, and we'll send out details of what that means when we do the communication. But essentially what it does mean is that for some patients where there are particular and pertinent risk issues, we may need to have different arrangements in place. And again, what we'll do is take that on an individual case-by-case basis. But again, I want to go back to what I said at the beginning of this. We want to apologise. It's taken us a lot longer than what we really wanted to do. It would have been nicer if, for all concerned, if we'd have been able to get this turned on within the first couple of weeks of the lockdown. But because of the technical perspective and the issues with our network, that wasn't possible. So please accept my apologies for that.
Just to let you know that actually I'm going to be leaving the trust in a couple of weeks. I'm going to work in Scotland. So there's more than just one change in the senior team at the hospital. There's going to be 3. Sue Elcock, who's going to be talking to you in a little while, is a new executive director for forensic services, and I think this is day 11, isn't it, Sue? Yes. Adele is taking over from me. Well, she's on a handover period at the moment, so she'll be the interim deputy director of forensic services for the next 12 months. Then Anna Simpson, who I don't think many of you will know, but she's been working elsewhere in the division in Avenda Health Services. She's coming in as interim director of head of clinical operations for 3 months, and was Adele's post. She starts on the 22nd. So it's just to give you a bit of an overview of some changes, and hopefully you'll get to meet those folk either on the calls or in person as we go along. Okay, so this is the main things we're going to look at today. I'm going to hand over to Adele to talk about CQC update, and then I'll look at service developments, including Rob doing physical healthcare, and I'll also talk about COVID-19 from the day that we had to lock down to where we are now and what our future plans are. And hopefully within that part, I'll be able to answer the questions that have come up from carers on the sheet. So Adele, did you want to talk about CQC inspection first?
Absolutely. Yep. Good morning, all. As you probably remember, some time ago, I came to the carers event and talked about some work we'd been doing in the Learning Disability Directorate, and that looked at the pathway for the patients. Some of that derived from when we did a bit of feedback session. We got the involvement team in and asked the patients really what they were feeling like and how their experience was. And that drove some sort of quality improvement work. And that was mainly around patients felt they were just stuck and there was nowhere for them to go through their pathway for stuff like low dependency wards and stuff. We also looked at what the national agenda was looking like, and that was around autism, a ward for autism. And we have got quite a few patients with a diagnosis of autism in the learning disability services and didn't really have a designated ward for those. So if you remember, I came and sort of gave you the presentation of what the ambition was for the LD service, the pathway, and we've made those changes. In March, the CQC came in and wanted to sort of explore changes in the LD services, but also find out from the patients and the staff what their experiences has started to be, and after some concerns which was raised regarding patients' wellbeing and stuff. And I'm really happy to report that we got the report back a week last Friday. It's published if you haven't seen it, and the report is really, really positive. The patients have basically stated that they feel really cared for, being involved in their care, and the staff, the morale of the staff within the environment is really positive. I won't go through all the report because it'll be there for you to have a look at on the CQC website. Not many recommendations came from that CQC inspection, which is very unusual for any inspection. The positive behavioural support and a lot of the designated training for learning disability services was commended, and I'm really, really pleased to report that we've got a very, very good outcome to the CQC inspection. We've just got to make sure that's maintained, which we are doing, and that is then sort of widened out to the rest of the hospital.
Okay, so moving on to service and developments. As I mentioned, there's been a lot of improvement work going on in the hospital. We got pre-COVID and during COVID, because we're not complacent about the CQC concerns that were there when they came last year. We've got to keep those going and keep the momentum going. And one of those relates to the review of therapies provision that's mentioned there. What's happened around the COVID time is that each ward has worked in a bubble so that they don't move and mix with patients from other wards. So to achieve that, the therapy staff have been going to those wards and working dedicated time on each ward every day. So there's been actually more on-ward therapy than we've ever done before. And whilst we need to move back from that a little bit, because we need patients to be going off to their very specific therapy areas to do assessment centre work or work skills, we do acknowledge that it's been a really positive thing for some patients, and we've found that some patients that have struggled with therapies in the past have really engaged very well with this. So part of the review, which we were going to do anyway, we'll be looking at what do we learn from this time, what has gone really well for patients, what hard to reach people have we actually reached by doing it differently. So the therapies review will cover that. It's also going to look at every aspect of therapy we do. Do we need more of speech and language? Do we need less of something else? Do we need more a different type of fitness and leisure? All of those things will be considered. And it's not about reducing the therapies that we do, it's actually looking at how we do things differently. So I think it would be useful probably for perhaps the next carers meeting, once we've got a bit of an idea of views inside the hospital from staff and patients, if we come to carers and ask your views as well. I think James can take that forward for us, I presume. In terms of other improvement work, we've been doing a lot around physical health care, and I'm just going to pass over to Rob if he could talk about both the stuff we've been doing in terms of COVID, so Nightingale and physical health, but generally where we are at the minute. So over to you, Rob.
Morning, happy Saturday, everyone. Great to be here. I'm Rob Furby. I'm the new modern matron for physical healthcare. So I started on the 1st of April to replace Marina Gibbs. I'm relatively new to Rampton. I've been here about 10 months all in all. My background's mainly intensive care and critical care nursing, and I've come from a big teaching hospital down south. So I'm new to Rampton, but I'm hopefully going to bring quite a lot of good stuff. So as always with these things, when you get a new job, it's always the worst time, isn't it? And particularly COVID's been challenging for physical healthcare. So we've done quite a considerable amount of work in quite a short period of time. So the first kind of big project that we've been working on is our Nightingale ward. So most of you will have heard about the big Nightingale hospitals that have popped up in exhibition centres across the UK. And we felt that with the patients that we care for here at Rampton and across the rest of the secure mental health sites, that actually our patients are pretty special and they need some specialist intervention, and then we need to focus not only on their physical health care when they're poorly, but we need to continue to maintain their mental health care. So we looked at a model of nursing that enabled us to do both of those things in the same place. So we built Nightingale and we staffed it as physical healthcare nurses and as mental healthcare nurses in partnership together, which is the first time we've nursed like that. And it's kind of the only unit really in the country that was doing that model of nursing, where we were having physical and mental health and learning disabilities nursing working together. We kitted it up as an acute hospital, so with the hospital beds, the specialist mattresses, oxygen, ability to give medications into veins, being able to monitor patients really closely. We had our colleagues from physiotherapy and occupational therapy, speech and language coming to work on the wards to give us a really good offering of physical health care in a mental health hospital. So that took a lot of work, and we got the unit up and running quite quickly. We've been lucky really that there's only been one patient that's needed that service, which is really good. But it is there and it's currently on hold and on standby as we kind of work through the rest of the COVID times. So that's kind of our big first project. A couple of other really big projects is around the use of advanced nurse practitioners. So we've always had an advanced nurse practitioner in the health centre, and he normally does a lot of things around managing people with long-term conditions like asthma, diabetes. But the offerings for if people become acutely unwell is kind of limited because he's caught up doing that long-term stuff. So we've been able to offer a 24-hour advanced nurse practitioner service who have been able to support not only that long-term condition management stuff, but also more urgent care. So being able to see patients when they're unwell, being able to see them in their own environments, being able to diagnose them with conditions, order tests, etc., give them a diagnosis and help support them with a management plan. We've also increased the number of hours that the GPs work. So we usually have a GP 3 days a week. We've been having a GP 5 days a week during Nightingale because they have been supporting with the Nightingale patients, but also been around to support us. And while we've dialed that back a little bit because we haven't got any patients on Nightingale, we are in the process of reviewing actually how often the GPs come to Rampton, what work they do, can they support patients with really complex physical healthcare problems more closely, allowing the advanced nurse practitioners to pick up more of the day-to-day minor illness, minor injury type activity. We're also doing a really big project around the computer systems that we use and looking to make sure that actually everybody with a long-term condition, any patients with learning disabilities, actually get the best evidence-based support to help them manage their long-term conditions. So that's a national programme called the Quality Outcomes Framework, and that looks at all the things every year that we need to be doing for patients. So there'll be a big drive from the health centre to actually get patients up to the health centre to be able to make sure that we're monitoring their physical health care as robustly as we can. To help support that, we've recruited new staff into the health centre to make an escort service, so to allow us to go out and collect patients from their ward environments and bring them to the health centre, which is promoting dignity, privacy. It makes sure that they're in an environment that's set up to be able to deliver that. All the equipment's on hand. Our physical healthcare practitioners have got somebody to call on if they need any support, and it kind of gives them an opportunity to get off the ward and kind of follow what would be a normal model of accessing physical health care if they were out in the community. So there's been lots of stuff happening in the health centre, loads more to come. So I'm hoping to join you for as many of these events as I can do and try and keep you up to date with what we're doing.
Fantastic. Thank you very much, Rob. OK, so if I talk a little bit about COVID at this point, when we were first in the position, as with everybody, that we were told everything had to lock down and we were significantly restricted because of the risk, we very quickly as a trust had a setup of meetings. So there was a daily meeting for the whole of the trust to phone into, give updates on where we were from everything, including staffing, PPE, etc. And then locally at Rampton, we had a local one of those 3 times a week, and one for the division. So we had lots of structures. Teams was a godsend, this was, because we were able to quickly communicate people, have a conversation, make decisions and move things forward. And certainly a lot of the things that we changed very quickly, the Nightingale ward, for example, we went from it being a ward full of mental health patients to being a physical health ward set up with an entire staff team in 3 weeks, which was pretty amazing. And we had all volunteers, every single member of staff that worked on that Nightingale from the mental health point of view were all volunteers from across the hospital. We put lots of things in place to ensure safety in terms of, like I said, patients being in isolation, staff not moving all over the place. So things like ward rounds continue to happen, but a lot of the MD team members have been using Teams to phone in rather than traipsing in and out of multiple wards. So we've tried to sort of minimise the risk of cross-infection, to the point where at the moment we've only got 1 ward in isolation, and that's a precautionary measure. We had the maximum we had at one given time was 9 wards in isolation, because of patients who were symptomatic or people who had tested positive. So we've gone down to a really low level. We've got single figures of staff that are off sick at the moment with symptoms, and again we're feeding into the national programmes around things like the test and trace and the antibody testing. So all of that's happening as well. In terms of what we've done patient-wise, initially we did continue to have patients going off wards to some activities in a very limited way, but as things stepped up a bit, we closed all of our activity areas and focused things down on the ward. What's good to say is that we've started to slowly open those up now, but we're doing it in a very measured way. So each of the areas has their own day centre. So for women's, it's the DRC. For Peaks, it's CRB. Southall for learning disability, and we're using the recreational hall for mental health. So rather than patients just going completely across the hospital, they all have 2 half-day sessions for each ward in those specific areas, doing more sort of concentrated, dedicated therapy that they would have normally done anyway. And the idea of that is they do half a day in that area. The area is completely cleaned for the next ward to go again. And we're looking at how we develop that on and build on that and open up a few more areas, but again, in a very slow way and very safely. I know one of the questions was about access to the Westfield. We have actually, initially, we stopped having ground access in terms of the patients that were allowed to go out on their own for ground access, because we were trying to use as many different areas for wards so that wards weren't going to the same areas and cross-contaminating those areas. So we did limit ground access initially, but again, we've put a lot of that back. Sessions are slightly shorter so that the wards can go out for their fresh air, but we are putting back in the fresh air sessions so that patients have more access again. There was a query about PPE for patients. We have had challenges around PPE because the personal protective equipment, the masks and the visors that we get, as a trust, we do not order them. We get what's sent to us nationally. So we're certainly in the earlier stages, we were 100% reliant on what just appeared at the door, if you like, every day. We had deliveries from the army would come into Nottingham, and then they were dispersed around the trust. And the reality is we had to focus on getting that personal protective equipment to the ward staff that were working most closely with the patients. And what we really worked on and focused with the patients was around social distancing and keeping the distance from each other as a protective factor rather than actually wearing masks. We've also changed the layout of some of the wards. So, for example, the women's wards, the day areas are relatively small. So we've actually split off some of those areas into the dining areas. So patients have got somewhere to sit, but they can still sit far enough apart from each other. And obviously the staff are all wearing protective equipment. And that will continue. We will be extending that in line with the government's requirements. There was also a query in terms of the scaffolding on E-block, and the delay with that has been somewhat COVID related because a lot of the works on site have been delayed by contractors being furloughed. So we've not been able to get the people in to do the work. Or our own staff being off because of COVID. So some works have been delayed, that is one of them, but we are beginning to see that movement now and we're getting progression. So the work we're doing on the library is now going to start again soon. And like I say, a lot of other things are starting to come back. Equally, CPA reviews, we've had some CPAs where they've been essential going on, but now the CPAs are going to be fully happening again. But again, we're looking at how we do that with the use of technology and how we can support carer involvement in that. We're also looking at other sort of things that we need to put back in place for patients. So again, Lee talked about social visits, but we're also looking at professional visits. We are still admitting and discharging. We did have a period when that was only for really urgent situations. And if somebody was going to a place that had got COVID positive patients, we wouldn't send them there. So that there was a bit of curtailment of admissions and discharges, but that's back fully happening now. So we've tried to be really measured in the way we think about things. The trust has made decisions based on the national guidance, and Rampton's sort of developed that further for our specific environment.
So I'm Sue Elcock. I've just started, as Louise said, it's day 11 for me in the trust. So I'm the new Executive Director of Forensic Services. And I think before you probably have met Julie Hankin, who was covering it as the interim. So I worked in the trust well, I left 5 years ago, actually, but I joined the trust originally back in 1999. So I'm a forensic psychiatrist by background, and I did a lot of my junior training. Then I did a lot of my senior training across all the different forensic services. And then some of you may, because I know there's quite a lot of colleagues as well as carers on the call. So I became a consultant in the women's service at Rampton back in 2005. So I worked in Rampton then for 10 years. And I think, obviously, I've worked with Louise and Adele over that time period. And one of the things that we were really passionate about was about patient involvement, particularly in things like training. And so I left the trust really proud of what had been done, obviously, particularly in the women's service, about sort of patient involvement. And patients actually doing a lot of teaching, training, education of staff, which we found really helpful. So coming back now as the director of the service for me is a real privilege, actually. I'm really pleased to come back. And have to say, after 2 weeks, it does feel like I've never left. Obviously, I spent the first 2 weeks mostly at Rampton just by virtue of meetings. But next week I start to get out across the different services out into Nottingham, Leicester, and then I'm going up, I think, to Wathwood and some of the prisons throughout June and July. So for me, it's really lucky that this is on just as I've started, so that everybody can get a sense of me and I can see what sort of involvement we're doing. And this morning is really helpful, hearing what we've heard. I think I wanted to really thank Louise. I know she's mentioned briefly, very sort of shyly, I think, that she's leaving. But I've known Louise and worked with her for a number of years. She's worked a long time in the trust and she's contributed across every service, really. And so I think I really did want to take that time, because for me, it's a real personal sort of loss that she's leaving. But then on the other hand, it's a great opportunity for her. And I know that Scotland, is very lucky to get her. And obviously, we've now appointed Adele, who I've also worked with. So although I'm sad to see Louise go, it's also a great opportunity for Adele and I to work very closely together, which I'm really pleased about.
Well, thank you, everyone. Thank you to Lynn, Lee, Louise, Adele, Rob and Sue for your updates. It was muchly appreciated and I'm sure very, very informative to everybody who was listening.